In your college only?
Yeah.
Post graduation, your college only.
Yes, sir.
Right, sir. You can start, sir.
Okay. Good evening, everybody. Today is Wednesday. Time for Pudukkottai Budan, a weekly webinar from ISA Pudukkottai branch. Today we are going to witness the 20th webinar of our efforts. At the outset, I invite our Honorary Secretary, Dr. Priyasamy, to welcome the address, welcome the speakers and guests. Over to Dr. Priyasamy.
Thank you, sir. Thank you, sir. Good evening to all. Respected Academic Chairman Dr. A.L. Meenachindram sir, President Dr. Suresh Kumar sir, President Dr. David, and member of ISA Pudukkottai, and members, delegates from various parts of the country, and I welcome you all for this Pudukkottai Budan. On behalf of ISA Pudukkottai, I once again welcome you for all for this 20th ISA Pudukkottai online program Pudukkottai Budan. So this is successfully conducting 20th program of this week. Either Wednesday may come or not, but Pudukkottai Budan definitely will come at 6 o'clock on every week. This success because of our Academic Chairman Dr. A.L.M. sir. On behalf of ISA Pudukkottai, though he is member of our society, I wholeheartedly thank our Academic Chairman for his effort, hard work, and skin from the beginning. Thank you, sir. Once I thank you wholeheartedly on behalf of ISA Pudukkottai, sir. So this is a list of various topics that have been taken for the past 20 weeks. Last week, the program was talking about management of option for chronic pain, celiac plexus block, and kid control theory. But this week, we are going to talk about lung-related anesthesia topics. For that, I welcome Dr. Jaishankar Jana. So once again, sir joined with us as a chairperson, senior consultant at Chem Hospital, Pune, Maharashtra. I welcome you, sir.
Thank you, sir.
As speakers, we are having three eminent persons here. Dr. Veerasam, Professor, Great Eastern Medical School and Hospital, Ragalu, Srikakulam, Andhra Pradesh. Sir is going to talk about anesthetic management of bronchopleural fistula. This is a rare but more important topic for anesthesiologists to share the airway with the surgeons. I welcome you, sir.
Thank you, sir.
Another speaker, Dr. Sindhura K, Assistant Professor, Great Eastern Medical School and Hospital, Ragalu, Srikakulam, Andhra Pradesh. Madam is going to talk about lung function tests. I welcome you, madam, on behalf of ISA Pudukkottai.
Thank you, sir.
Another intern, resident, Dr. Samir Naga Vinit Bandi, resident, Great Eastern Medical School and Hospital, Ragalu, Srikakulam, Andhra Pradesh. Sir is going to talk about iGel. I welcome you, sir, on behalf of ISA Pudukkottai.
Thank you, sir.
And one more thing, our CME program was accredited by Medical Council of Tamil Nadu, and they are giving credit hours for this program. For that, you have to pay 100 rupees for us in the mentioned bank account. And details required are email ID, attendance, and name in medical council registration. With these particulars, send 100 rupees for us in this bank account. And whole things have to send a ISA Pudukkottai at yahoo.com email ID. This is more important, those who want credit hours of Medical Council of India. With this, I conclude my welcome address. I thank Akurula for continuous support and Eon Logistics for uninterrupted broadcasting of this event on every week. Welcome, and once again, welcome you all, and thank for the opportunity. Thank you, sir.
Thank you, sir.
Thank you, Dr. Periyasamy. Dear Secretary, respected our academic chairman, Dr. A.L. Meenakshi Sundaram, Treasurer David, the members and executive officials of our local branch, Pudukkottai, and state branch and national branch. Our chairperson of today's event, Professor Dr. Joy Shankar Jana sir. Speakers from Andhra Pradesh Great Eastern Medical School, Professor Dr. M. Veerasam sir, Dr. Sindra madam, and Dr. Samir Naga Vinith Bandi. Postgraduates, practicing anesthesiologists who are assembled here. On behalf of ISA Pudukkottai, as President of ISA, I welcome you all for this gathering. Today, the topic was wisely and brainly chosen. It blends both postgraduate, practicing anesthesiologists, and the old anesthesiologists like us. I have a good refresher of the knowledge of thoracic anesthesia. So I sincerely request everybody to participate in the webinar fully, make use of it, and actively put questions in the chat box so that it will be a useful discussions, well managed with our Dr. Joy Shankar Jana. I request our academic chairman to go with the other things. I hand over the mic to Dr. A.L. Thank you. Thank you.
Thank you. Thank you, Mr. President. President, Secretary, Treasurer, and the members of Pudukkottai, respected faculty today, I welcome you all personally on my behalf. Today it is a wonderful day that we are having great speakers from Great Eastern Medical School. And I want to introduce this time our long-time friend, Dr. Veerasam. Veerasam is a very nice man. I know him for the past 4 years, but he has created an impression that as if he is known to me for the past 40 years. See, that is the advantage of Dr. Veerasam sir. He will be very friendly. He will be very friendly, and he is very innocent. That is another point. He is very innocent. He is a professor of anesthesiology. This is Srikakulam, GEMS, Great Eastern Medical School. See, usually we will fight with the airway. We will find it difficult whenever a person is operating the airway, and we used to share the airway with the surgeon. Even our secretary has mentioned that, but today he has not quoted any poem on this thoracic anesthesia. Usually he'll come out with a poem, but sir will not share the airway. He will complement the airway for the simple reason he is a ENT graduate. He is a ENT graduate, switched over to anesthesia. So he is MD DLO. That's what I want to convey. So he is the right person to talk about the surgeries on the airway. He is Osmania Medical College Alumni Association president, and he has retired from government service and he has joined the private college. So he is the president for the Pensioners Association. Moreover, he is correlating himself with Dr. Periyasamy, our Tamil Nadu Government Doctors Association. Sir is also a Government Doctor Association former president. So he is an active agitator and he is an academic director in IMA Telangana. And moreover that, he is the president ISA Telangana state. So now we are having access to the Telangana state. He is the president. He is an election committee member for Hyderabad city branch. And he has received a proficiency award from ISA National. And he has toured the entire country as an external examiner for MD anesthesia and dip MD anesthesia postgraduates. So Dr. Sindhura happened to be her student. She is the youngster. She has finished her anesthesiology only 2 years back, but she is interested in teaching. She is continuing in the same medical college where she was graduated. And she did his undergraduation from PES Medical College, Kuppam. Even I have visited there to address the students on management of shock. At that time, retired DME was the Dean of PES Medical College, Kuppam. So I went there. So when I have seen that she has studied from PES Kuppam, it reminded me. And today, as usual, we will have a resident compulsory. So we are having a resident with the lengthier name possible. So far, out of all the residents, he is the one, he is having 4 words, just like a Telugu movie I quoted, but he is having a very short topic as IGEL. It is only 4-letter word, but he is having 4 words in his name. Today, 4 faculty. So today I think it is 4, and that boy, even though he is a youngster, even during his post-graduation, he has presented 2 papers. He is only a final MD postgraduate. He has presented 2 papers in ISA Karnataka. He did his undergraduation from Karturi Medical College. The paper presentation is funny. He has presented a paper, right licorolaryngeal nerve palsy after thyroidectomy. And another one is a comparison of epidural butorphanol with tramadol. So he has the inclination towards teaching and research. So we invite all of them, and Pudukkottai branch feels honored to have them as faculty. And again, to control everyone, we need a good chairperson, and that chairperson is a repetition again. Dr. Jana previously was a speaker. So far as my knowledge goes, I have introduced in length only about Dr. Jana. Yes. Mostly 12 minutes, I think more than 12 minutes I talked about Dr. Jana last time, because he is just like my kith and kin. I have moved it. And today I put up a new thing about him. He is known as a transplant anesthetist everywhere, because he is known for his uterine transplant, then kidney transplant, liver transplant, everything. But he is doing a lot of thoracic procedures also in KEM hospital. So we want to have Jana as the chairperson for that. He is Jai Shankar Jana, and mostly in Tamil Nadu he will be pronounced as Jai Shankar Jana, because Jai Shankar is a famous actor here. And now only my name is correctly pronounced as Meenakshi Sundaram in the northern part of the country, or else they will write as MINAXI. Same way, this sort of exchange programs make us, now our secretary is pronouncing Samir Naga Vinith Bandi. That is the best thing about this webinar. Today we are really happy, and we are, as usual, our target is only 50. We are nearing 50. Now I hand over the session to Dr. Jai Shankar Jana, chairperson. Thank you.
Thank you, sir. I welcome all the honorable members of ISA Pudukkottai, and this is the 20th session. And I thank the President, sir, Secretary, sir, and Treasurer, sir, and of course, our academic chair, Dr. Meenakshi Sundaram. So without wasting any time, I'll invite the first speaker, Dr. Samir. He is the 3rd year postgraduate resident, and I'm very glad that at this level you have presented so many papers. So the first topic is IGEL. Samir, try to stick to your time so that we can take more and more questions. You can type all the questions on the chat box, and we'll take it at the end of all the presentations. So over to you, Samir.
Yes, sir. Thank you, sir. Thank you, ISA Pudukkottai branch, especially for giving me this opportunity. Good evening, everyone. Respected dignitaries, ISA Pudukkottai. Today's topic of presentation is about IGEL and Dr. Samir Bandi, finally postgraduate from Great Eastern Medical School and Hospital, Srikakulam, Andhra Pradesh. Coming to the introduction, IGEL is a supraglottic airway device, which is innovative supraglottic airway management device, which is made up of medical grade thermoplastic elastomer called styrene butadiene styrene, which is transparent. And the IGEL is designed to create a non-inflatable endemic seal of pharyngeal, laryngeal, and perilaryngeal structures while avoiding the compression trauma that can occur with inflatable supraglottic airway devices. This device has been developed after extensive literature searches related to supraglottic, extraglottic, periglottic, and intraglottic airway devices dating back as far as the 5th century, dissected and preserved human cadaveric models, fresh cadaveric neck and airway dissections, direct and indirect pharyngo-laryngeal endoscopies, X-rays, CT and MRI imaging data were all studied in detail, scientifically investigated, and critically examined in development of this IGEL. This knowledge was utilized to ensure the IGEL shape, softness, and contours accurately mirror and exert the least possible pressure onto the pharyngeal, laryngeal, and perilaryngeal framework. Brief history. He is Dr. Archie Brain. All of us are aware about him. He is the first person who introduced the LMA, laryngeal mask airway. This is the Goldman mask. He just fitted the Goldman mask into a 10 mm internal diameter plastic tube and finally made the prototype of an IGEL, prototype of an LMA, which later came into the market in the year 1987 as LMA Classic. And he is Dr. Mohammad Nazir, who is the developer of IGEL. He's a Pakistani scientist. He collaborated with Intersurgicals Corporation Limited from United Kingdom, and he emphasized the development of IGEL in developing the shape of the IGEL, in developing finally producing the product of IGEL. Coming to the brief classification about supraglottic airway devices, they are broadly classified into 3 types based on generation, based on whether the cuff is present or not, and based on the suction port. And our IGEL comes to the 2nd generation, non-cuffed and channeled supraglottic airway device. IGEL actually covers the laryngeal, perilaryngeal, and pharyngeal structures. The soft, non-inflatable cuff will cover the tongue, base of the tongue, epiglottis, array-epiglottic folds, piriform fossa, posterior cartilages, thyroid cartilages, cricoid cartilages, and upper esophageal opening. And these are the key components of the IGEL: the soft, non-inflatable cuff, the gastric channel, epiglottic rest or epiglottic ridge, and buccal cavity stabilizer, integral blind block, and the universal 15 mm connector. Coming to the components in detail, this is the soft, non-inflatable cuff. It is made up of a chemical called styrene butadiene styrene. It is soft, non-inflatable, snugly fits onto the laryngeal and perilaryngeal framework, and receives an impression fit thus supporting the seal by enveloping the laryngeal inlet. The tip lies in the proximal opening of the esophagus, isolating the esophageal opening from the laryngeal inlet. The outer cuff shape ensures that blood flow to the laryngeal and perilaryngeal framework is maintained and helps to reduce the possibility of neurovascular compression. Sliding past the pharyngoepiglottic folds, it becomes narrower and deeper, creating an outward movement to fit snugly into the potential space of the perilaryngeal pouch. Coming to the gastric channel, there is a proximal end and there is a distal end. Proximal end, the gastric channel actually has been introduced into the IGEL to combat the complications of aspiration, to combat the risk of aspiration during intubation. The gastric channel runs through the device from its proximal opening at the side of the flat corner wing to the distal tip of the non-inflatable cuff. Since the distal tip of the device fits snugly and anatomically correctly into the upper esophageal opening, the distal opening of the gastric channel allows for the passing of a nasogastric tube to empty the stomach contents and can facilitate the venting of gas from the stomach. The gastric channel can also provide an early indication of regurgitation. Coming to the epiglottic rest, epiglottic ridge, also called as epiglottic rest, actually is of the bowel rests at the base of the tongue, thus keeping the device from moving upwards and out of the position and the tip moving out of the upper esophagus. It is an artificial epiglottis and a protective ridge which helps in preventing the epiglottis from falling downwards or obstructing the distal airway opening. And coming to the buccal cavity stabilizer has a built-in natural curvature and an inherent propensity to adapt its shape to the oropharyngeal curvature of the patient. It is anatomically widened and concaved to eliminate the potential for rotation, thereby reducing the risk of malposition, and it also provides vertical strength to aid insertion. universal 15 mm connector, which is also we commonly see at the distal part of the ET tube, and it provides standard 15 mm connection to the anesthetic system or patient connection, a port of entry for the gastric channel, which is present on the right hand side of the connector wing, and integral bite block, which functions as is provided by the distal part of the connector, which runs through the center of the proximal part of the buccal cavity stabilizer. As a guide to correct positioning, the integral part of the bite block is marked with a horizontally placed black line, which we can see here, which signifies the optimum position of the teeth while the device is in situ, which is not applicable to pediatric sizes, because in pediatric age group, the oropharyngeal laryngeal structure sizes are not specific. They change from patient to patient. So this black line is not commonly seen in the IGLs, which are of sizes of 1, 1.5 and 2, 2.5. Easy visibility of key product information like the size of the IGL and the weight to which the IGL should be used is also printed on the integral bite block. Coming to the indications of the IGL, IGL is primarily used by medical staff and paramedical staff in difficulty or unexpectedly difficult intubations in a pre-hospital setting in order to quickly establish and maintain a clear airway. Securing a clearer airway in difficult or unexpectedly difficult intubations in airway management of a patient in the operating theatre, and in a known difficult or unexpectedly difficult intubation for intubating the patient by passing an endotracheal tube through the device under fiber optic guidance. The IGL is indicated for using securing and maintaining a patent airway in routine and also emergency anesthetic of fasted patients and during spontaneous or intermittent positive pressure ventilation during resuscitation of unconscious patients. Coming to the interesting feature about IGL, IGL can be used as a conduit for endotracheal intubation. You can see here in the image, the flexible fiber optic bronchoscope has been passed through the IGL, and it is used as a stillet for the passing of ET tube through the IGL into the larynx or trachea. And here this chart shows the size of the endotracheal tube, which can be accommodated into the size of the IGL. The IGL sizes vary from 1 to 5, and the size of the IGL, which can accommodate 3 mm endotracheal tube is size 1, and 1.5 can accommodate a size of ET tube of 4, and 2 size IGL can accommodate around 5. 2.5 can also accommodate an ET tube of size 5, and 3 size IGL can accommodate a ET tube of size 6. And IGL 4 can accommodate an ET tube of 7, and IGL 5 can accommodate an ET tube of internal diameter 8. Coming to the contraindications, it cannot be used in non-fasted patients for routine and emergency anesthetic procedures. Though it has a gastric channel to prevent aspiration, but in non-fasted patients, there is high chance of aspiration, and we cannot secure the airway properly with the IGL because IGL is not a definitive airway when compared to the routine endotracheal intubation. Trismus, patients who have trismus and limited mouth opening, pharyngo-perilaryngeal abscess, trauma or MOS, in these patients also we cannot use IGL. And we cannot use excessive force to insert the device or nasogastric tube, and inadequate levels of anesthesia, inadequate depth of anesthesia, which leads to coughing, bucking, excessive salivation, retching, laryngospasm or breath holding, will complicate the anesthetic outcome. And we cannot leave the device in situ for more than 4 hours. So surgeries which prolong for more than 2 hours or 3 hours, we cannot use IGL for those surgeries. And we cannot reuse the IGL. It is always a single-use latex-free material which is made for using for one time. And patients with any condition which may increase the risk of a full stomach like hiatus hernia,
No audio and video.
Video is there, no audio.
Yeah, video is there, no audio.
Dr. Samir, you check, there is no audio.
sorry sir, there has been a power disconnection. Sorry for the disturbance. Audible? Am I audible?
Yeah.
Continuing, sir.
Yeah.
Inadequate levels of anesthesia, which may lead to coughing, bucking, and exacerbation, retching, laryngospasm, or breath holding, thus complicating the anesthetic outcome. Do not leave the device in situ for more than 4 hours, and patients with any condition which may increase the risk of stomach, like hiatus hernia, sepsis, morbid obesity, pregnancy, or a history of upper gastrointestinal surgery. Coming to the warnings, IGL must be lubricated before using it. We can lubricate it with the lignocaine jelly, and the patient should always be in the sniffing of the morning air position prior to the insertion. The assistant helping to open the patient's mouth unless head or neck movements are considered or contraindicated. Optimum depth of anesthesia must be achieved prior to attempting insertion. That is, absence of eyelash reflex, easy up and downward movement of the lower jaw, no reaction to pressure applied to the both angles of the mandible. The leading edge of the IGL tip must follow the curvature of the patient's hard palate upon insertion. If there is a failure to achieve complete insertion after utilizing the standard insertion technique and a jaw thrust, deep rotation or triple manual has also failed, then the device should be inserted under direct vision by laryngoscopy, or one size smaller device should be used. After insertion, the IGL should be tapered down from maxilla to maxilla. Excessive manual ventilation is primarily due to either suboptimal depth of anesthesia or suboptimal depth of IGL insertion. Particular care should be taken with have an ASA or multi-party score of 3 and above, or who have fragile and vulnerable dental work in accordance with recognized airway management practices and techniques. No attempt should be made to use IGL as a conduit for intubation without the fiber optic guidance. Coming to the preparations for use, here is a size chart which we have already seen. The IGL size can be used in the patients of weight 2 to 5 kgs, and 1.5 can be used for the patients of weight 5 to 12 kgs, and IGL size 2 can be for the patients of weighing 25 kgs. IGL size of 2 can be used for the patients weighing 25 to 35 kgs. IGL size 3 we can be used in small adults with a wide range of weight from 30 to 60 kgs. And IGL size 4 can be used in medium range adults with a patient weighing 50 to 90 kgs. And IGL size 5 is used usually 90 plus kgs. Most commonly we use IGL size 3 and IGL size 4 in our hospital setup. Patients with cylindrical necks. Patients with cylindrical necks, thyroid or cartilages may require a larger size IGL than would normally be recommended on a weight basis. Equally, patients with a broad or stocky neck or smaller thyroid cartilage may require a smaller size IGL than would normally be recommended on a weight basis. So, smaller thyroid cartilage, smaller IGL size; larger wide thyroid cartilage, larger IGL size. Patients with central obesity, where the main weight distribution is around the abdomen and hips, might in practice require an IGL of a size commensurate with the ideal body weight or height rather than the actual body weight. Induction of anesthesia with the IGL. Ensuring depth of anesthesia is always paramount importance. We should check to ensure they have reached the optimal level of IGL insertion by checking loss of eyelash reflex, jaw lift, jaw movements by moving up and down easily, and no response to painful stimulus at the angles of the mandible, and muscle relaxation with the use of a neurostimulator. Pre-medication with benzodiazepines, glycopyrrolate and opioids is a requisite, and induction with propofol, thiopentone, or other barbiturates like etomidate or ketamine can be used. Induction should be followed by manual ventilation with a bag and a mask with oxygen or nitrous oxide and an inhalation agent, preferably sevoflurane or desflurane, or relaxation. The Buccal airway may be used to facilitate manual ventilation. For the purpose of IPPV, we can use a muscle relaxant like atracurium, vecuronium, or rocuronium. Insertion technique. Usually, a proficient user can achieve the insertion of IGL in less than 5 seconds. Grasp the lubricated IGL firmly along the integral bite block. Position the device that the IGL cuff outlet is facing towards the chin of the patient. Okay, as you can see in the picture, the patient should be in the morning air, between the morning air position, extension and neck flexion, and the chin should be gently pressed down before proceeding the insertion of the IGL. Introduce the leading soft tip in the mouth of the patient in addition towards the hard palate. There is a difference between IGL and LMA while introducing. Usually, while introducing an LMA, we'll take the guidance of our index finger. But in case of IGL, we need not use the fingers. We can hold the IGL in our hand at the site of integral bite block, and we can directly insert the IGL by pushing it towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. At this point, the tip of the airway should be located into the upper esophageal opening and the cuff should be located against the laryngeal framework. It is essential that as soon as insertion has been successfully completed, it should be tapered down from maxilla to maxilla. You can see the gentle jaw thrust, and here we are after it is the sagittal section showing the insertion of the eye gel into the oropharyngeal and perilaryngeal structures. You can see the tip of the eye gel into the esophageal opening and the aperture of the cuff, which is actually opening into the trachea, and the epiglottis ridge is preventing the epiglottis to fall into the larynx. And sometimes, and here you can see the eye gel after insertion is fixed from maxilla to maxilla by tying with the tapes. And sometimes a feel of giveaway is felt before the endpoint resistance is met. This is due to the passage of the bowel of the eye gel through the fascial pillars carrying the epiglottic folds. Once the resistance is met and the teeth are located on the integral bite block, do not repeatedly push eye gel down or apply excessive force during insertion. No more than 3 attempts in one patient should be attempted. And maintenance of anesthesia, we can maintain using inhalation agents or total intravenous anesthesia. If we are using inhalation agents, we can use sevoflurane or desflurane and nitrous oxide along with nitrous oxide and oxygen. And more recently, total intravenous anesthesia has been has been a lot of emphasis on total intravenous anesthesia like propofol infusion, dexmedetomidine infusion, or remifentanil. And patients requiring intermittent positive pressure ventilation must require the intermittent bolus doses of muscle relaxants like vecuronium, atracurium, or rocuronium. Emergence from anesthesia, we can extubating or emergence from anesthesia on patients who have been on eye gel is very important. And if the inhalational technique for the maintenance of anesthesia was used, the anesthetic agent should be stopped at the end of the operation except the oxygen, and the patient will continue to breathe near 100% oxygen and the residual anesthetic gases in the breathing system before waking up. If TIVA was used, then the standard should be stopped just after the end of the operative procedure. A longer acting opioid or opiate is given and the patient allowed to wake up while breathing near the oxygen system. Patients on intermittent positive pressure ventilation, it is advised to monitor the neuromuscular blockade with a neurostimulator. At the end of the surgical procedure, either reverse the neuromuscular blockade or let it wear off until the protective reflexes and regular breathing pattern are regained by the patient before removal of the eye gel. Recovery phase of anesthesia and eye gel removal. The patient should continue to breathe higher concentrations of oxygen through an anesthetic system in the recovery room. The oxygen saturation are monitored consciously and blood pressure is measured at regular intervals. Once consciousness is regained and protective reflexes such as coughing and swallowing have returned, gently suction around the airway device in the pharynx and hypopharynx. Once the patient is awake and easily arousable with vocal commands, the eye gel can safely be removed by asking the patient to open his or her mouth wide and replace with a medium concentration oxygen mask. And in patients with the possibility of high-end gag reflex like smokers, asthmatics, and patients with COPD, eye gel should be removed in deeper planes of anesthesia, and after removal, their airway maintained with a Goodell's airway and oxygen mask until protective reflexes have returned and the patient becomes arousable. Do not attempt to forcibly remove the device if the patient is biting on it. Wait until the patient on vocal command has removed spontaneously. How to use the gastric channel. This is an innovative gastric channel which has been introduced in the second generation laryngeal mask airways, and we can see the size chart. The eye gel size 1, unfortunately, eye gel size 1 have no port for gastric channel. It starts from 1.5. 1.5 eye gel size can accommodate 10 French gauze nasogastric tube. 2 can accommodate 12 French gauze nasogastric tube, and 3 can accommodate 12 French gauze nasogastric tube. And 4 also can accommodate 12 French gauze nasogastric tube, and 5 can accommodate a 14 French gauze nasogastric tube. And patients who have who has been fasted patients for routine electro procedures has approximately 25 to 200 ml of residual gastric contents at any given time. This group of patients may not have any predisposing factors for regurgitation. If regurgitation is suspected for or noticed during anesthesia, then it is recommended the patient head end of the operating table is tilted down. If the timing of the surgical procedure allows, the patient is turned on to left or right lateral position. Eye gel should then be removed. Thorough suctioning of the pharynx and hypopharynx undertaken, intubated for definite securing of the airway. If the regurgitation is anticipated, then it is recommended that an nasogastric tube is passed through the gastric channel of the eye gel into the patient's stomach and stomach. Nasogastric tube can be left in situ during the whole duration of the operation or anesthetic. Do not use the gastric channel if. What are the contraindications to use the gastric channel? There is an excessive leak through the gastric channel, not use the gastric channel, And when there are esophageal varices, a risk of upper gastrointestinal bleed. In case of any esophageal trauma, and when there is any history of upper gastrointestinal surgery, and if the patient has any bleeding or clotting abnormalities, and nasogastric tube insertion in the presence of inadequate levels of anesthesia can lead to coughing, bucking, excessive salivation, retching, laryngospasm, or wet holding. Coming to troubleshooting, a horizontal line is present, as we already seen, at the middle of the integral bite block, and it is useful for the correct positioning. And if the removal if the teeth are located lower than the distal tip of the bite block, then it is likely that the device has been completely inserted. In this instance, remove the igel and reinsert with a gentle jaw thrust applied by the assistant. If that does not resolve the problem, use one smaller igel. In case of pediatric sizes like 1 to 2.5, do not have a horizontal line on the integral bite block. This is due to the greater variability in the length of the oropharyngeal laryngeal arch in children. As a result, insertion should continue as with the sizes until definitive resistance is felt. And once it has been established, the ventilatory parameters are satisfactory. There is no leak through the gastric channel except size zone, which does not have a gastric channel. The igel should be held in place while the device is secured with the tape maxilla to maxilla. Following of inadequate anesthesia at insertion or during maintenance of anesthesia, coughing and breathing may occur, signifying an inadequate depth of anesthesia. In this situation, anesthesia must be deepened by intravenous injection of an agent like propofol or with an inhalation anesthetic agent like sevoflurane. And patient is paralyzed and ventilated, adequate muscle relaxation and neuromuscular monitoring should be done. Should a patient show signs of gagging or coughing during the recovery, remove the igel and adequately suction the fins for reinsertion. Air leakage through the gastric channel. Any small air leak, air venting through the gastric channel may be useful mechanism to protect against the gastric insufflation, but an excessive leak means the device is incompletely inserted, and in such instances, remove the device and reinsert with a gentle jaw thrust applied by an assistant, a deep rotation or triple maneuver to achieve an optimum depth of an insertion. Inadequate seal pressure. We cannot, the seal pressure must not exceed 40 centimeters of water, and it has advised a larger size than recommended on weight basis if we require a high. When excessive air leak during intermittent positive pressure ventilation, hand ventilate the patient, gentle and slow squeezing of the reservoir bag, limit tidal volume to no more than 5 ml per kg, and limit the peak airway pressure to 15 to 20 centimeters of water. Assess the depth of anesthesia and muscle relaxation. Use pressure controlled ventilation. If all the above fail, then change to one size larger igel. Few studies shown that igel versus LMA classic, the insertion time was very, very less when it is around 10 seconds with igel compared to LMA, where the average insertion time was around 30 to 45 seconds. And the percentage of patients is more with the LMA, and patients who have coughed with LMA are more when compared to the igel, and patients who have complained with sore throat post-operatively are also with LMA. So comparatively, igel is better. Coming to the igel and the Buccal mask, you can see the Buccal mask here. Buccal mask is almost similar to igel. It has an additional gastric channel similar to igel, but the only different feature is it expands and collapses with the inspiration and expiration. While during expiration, it expands because of the presence of a additional dorsal cuff. So it again further protects the airway and prevents the aspiration of the gastric contents. You can also see here, but ease of insertion of Buccal mask when compared to the LMS or igel is difficult. So the ease of insertion and also the leak pressures are high with the Buccal mask when compared to the igel or LMS. And usually, I can be used as a better alternative to endotracheal tubes in laparoscope, pneumoperitoneum, Trendelenburg positions, and supine positions. This is the supine position where the patient is intubated with an LMA for a laparoscopic surgery, and this is the laparoscopic pneumoperitoneum Trendelenburg position. You can see the pressure, intra-abdominal pressure, and the pressure under the diaphragm. All these are pushing the airway upwards. This will further acts as an added advantage and causes helps in sealing of the esophageal opening and also further preventing the aspiration. So igel can be used as a better alternative when compared to the endotracheal tube in laparoscopic procedures which occur for a period of less than 1 hour or 2 hours. And the comparison shows leak fraction is almost higher when compared to the igel than compared to the comparison to the endotracheal tubes. So as we all know that igel is not a definitive airway, obviously leak fractions are higher with the igels, but when compared in supine position, the leak fractions are higher with the igels, but in laparoscopic Trendelenburg position, the leak fractions are almost same with the igel and the endotracheal tube. So this makes an additional alternative for the uses of igel in the laparoscopic procedures. And this is the LMA fast attach. which can be which we use for intubating the patients, which can be used as a conduit for intubating the patients, and IGEL can also be used as a conduit for intubating the patients. And we can see, as we already mentioned, we should not intubate the patient without the use of fiber optic bronchoscope for intubating the patient using an IGEL. And the comparative study between IGEL versus LMA fast stretch supraglottic airway devices, the first attempt success rate is higher with the IGEL, and ease of insertion is also higher with IGEL, and time taken for insertion is very less when compared with the LMA fast stretch, and airway seal pressures are higher in LMA fast stretch than the LMA. And when compared to tracheal intubation, fiber optic view is better with LMA fast stretch, and first attempt success rate is better with IGEL, and intubation time is less with LMA fast stretch, and ease of intubation is better with IGEL, and ease of removal of supraglottic airway device is the same. And coming to the adverse outcomes of the IGEL, the anatomical design and soft material of the IGEL is less likely to cause any adverse outcomes like trauma during the insertion while in situ, and thereby reducing the risk of respiratory complications and comorbidities. And clinical evidence currently available suggests IGEL may cause fewer secretions in the pharynx and hypopharynx. Some of the known risks and complications of the use of supraglottic airway device include laryngospasm, sore throat, trauma to pharyngolaryngeal framework, gastric insufflation, regurgitation, inhalation of gastric contents, nerve injuries, vocal cord paralysis, lingual or hypoglossal nerve injuries, tongue numbness, and cyanosis. But these risks are very less with IGEL, and risk of rotation and malpositioning leading to partial or complete airway block obstruction is extremely low with the IGEL compared with other supraglottic airway devices. Downfolding of the epiglottis can occasionally occur and may be more common in the children, but the IGEL cuff and the airway channel have been designed in such a way that the chances of obstruction to the fresh gas flows are minimal. If the IGEL is placed too high in the pharynx, this may result in a poor seal and cause excessive leakage. If the fresh gas flow is forced too hard by squeezing the reservoir back too quickly, this may cause gastric insufflation and distension, which will increase the risk of regurgitation, post-operative nausea, and vomiting. If the tip of the IGEL enters into the glottic opening, this can lead to an excessive air leak to the gastric channel, which may result in obstruction of the fresh gas flow. If a nasogastric tube is inserted into the IGEL, it will enter into the trachea and lungs. It is recommended that if the situation is suspected, the IGEL is removed and reinserted with a gentle jaw thrust, and correct placement is checked. Thank you.
Yeah. Thank you, Dr. Samir. You really extended, you spoke for more than 25 minutes. It's okay, but one thing is that your slides should be more spaced out, because it was too much of crowding of slides. You were just reading from the slides. Anyway, it's a good presentation. You have covered IGEL extensively, will be really good for all your postgraduates. So we'll take the questions at the end. We'll move on to our next speaker, Dr. Sidura ma'am. If you're ready, we can start. She's going to talk about the lung function tests, which is very important. We keep on always asking lung function tests. So she's going to tell us what are the types of lung function test, which type of lung function test you will advise at what type of lungs you have, and depending upon what type of lung function test, and what inferences you get out of this lung function test. I welcome Dr. Sidura. Ma'am, if you're ready, you can start.
Yes, sir. Thank you, sir.
Ma'am, stick to the time, please, because Samir took away with you.
So thank you, sir. Thank you, ISA Pudukkottai. A very good evening to all the respected dignitaries. And my topic is pulmonary function test. The learning objectives are introduction and classification, lung volumes and capacities, spirometry, brief note on body plethysmography, nitrogen washout method and helium dilution method, and bedside PFTs and its applications. Coming to introduction, for us as an anesthesiologist, PFTs are an important part of our pre-anesthetic checkup to evaluate the pulmonary status of the patient and to identify who are at risk of host of pulmonary complications, and to formulate a plan of anesthesia, and also to wean off a patient from ventilator in ICUs. We need to assess the four components of the respiratory system, that is airways, lung parenchyma, pulmonary vasculature, and the strength of respiratory muscles. These pulmonary function tests will assess the function of all the four components. PFTs are the group of maneuvers carried out using standard equipment to diagnose, determine the nature, severity, and progression of the underlying pulmonary disease. It also helps to assess the effectiveness of the treatment. These can be broadly classified as the 6, that is static function test, dynamic function test, diffusion lung capacity for carbon monoxide, to assess the respiratory muscle strain, cardiopulmonary exercise test, and metabolic measurements. Among these, static function test, dynamic function test, and the respiratory muscle strain constitutes the mechanical ventilatory function of the lung, and the diffusion capacity will assess the gaseous exchange. And metabolic measurements include ABG and body plethysmography, SpO2. Before going to spirometry, let's have a brief note on lung volumes and capacities. The tidal volume, there are 4 volumes and 4 capacities. And coming to tidal volume, it is the volume of air inhaled or exhaled with each breath during quite normal breathing. It is 6 to 8 ml per kg in an average adult. It increases with exercise. Expiratory reserve volume is the maximum volume of air that can be exhaled at the end of tidal exhalation. Normally, it is 1 to 1.5 liters. It is decreased in obesity, pregnancy, restrictive and obstructive lung disorders. Inspiratory reserve volume is the maximum volume of air that can be inhaled following a tidal inhalation. Normally, it is 2 to 2.9 liters. Residual volume is the volume of air that remains in the lungs at the end of maximal expiration, and it is normally 1.2 to 2 liters. It is decreased in restrictive lung diseases, pregnancy, and it is increased in obstructive lung diseases like COPD and asthma. Coming to vital capacity, it is the maximum volume of air that can be exhaled after a maximal inspiration. Normally, it is 4 to 4.5 liters. Vital capacity includes inspiratory reserve volume, tidal volume, and expiratory reserve volume. In other words, inspiratory capacity and expiratory reserve volume. Factors influencing vital capacity are both physiological and pathological. Physiologically, age, sex, ethnicity, and height. And pathological, obstructive and restrictive pulmonary diseases, abnormalities of chest wall, space occupying lesions in chest, diseases of respiratory muscles, and other abdominal conditions. Inspiratory capacity is the maximum volume of air that can be inhaled after a normal expiration. It includes inspiratory reserve volume and vital capacity, normally 3 to 3.5 liters. Total lung capacity is the volume of air in the lungs at the end of a maximal inspiration. It is normally 6 to 6.5 liters. So total lung capacity is the inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. In other words, it is vital capacity and residual volume. Clinical implications are it is increased in COPD and it is decreased in restrictive lung diseases. It is a very good indicator of a restrictive lung disease, and also we can grade the restriction based on the total lung capacity in a spirometry. Like normally it is more than 80% of the predicted value. If it is less than 80% and more than 70% of the predicted, we consider it as a mild restriction. If it is in between the 60 to 70%, it is moderate restriction. If it is less than 60%, it is severe restriction. Coming to functional residual capacity, the volume of air that remains in the lung at the end of a tidal expiration. Normally it is 2.5 to 3 liters. So functional residual capacity is the expiratory reserve volume and residual volume. The clinical implications of FRC are, it helps in oxygenation during expiratory phase of the breathing cycle. It decreases the airway resistance, work of breathing, and pulmonary vascular resistance. And it is increased in obstructive disorders like asthma due to air trapping, in emphysema due to loss of lung elastic recoiling. It is decreased in restrictive disorders, mainly lung fibrosis, opacity, and in supine position due to abdominal organs pushing the diaphragm against the lungs. Coming to dynamic lung capacity, like forced vital capacity, forced expiratory volume in the first second, FEV1 by FEV ratio, FVT, and maximum mid-expiratory flow rate. Forced vital capacity is the volume of air that can be forcefully and maximally exhaled after a maximal inspiration. Normally, it is more than 80% predicted for age, sex, and ethnicity. So, in spirometry, 80 to 120% of the FVC is considered as a normal. It is decreased in restrictive and severe obstructive lesions. In spirometry, if FVC is less than 80% but more than 70%, we consider it as a mild reduction in FVC. If it is 50 to 69%, it is moderate. If it is less than, severe reduction in FVC. Normally, it does not decrease much in mild obstruction, but in severe obstruction, FVC is also reduced. Coming to forced expiratory volume in the first second, that is the volume of air that can be forcefully and maximally exhaled in the first second of the maximal inspiration. That is, it is the volume of air that is exhaled in the first second of the forced vital capacity, and it is normally represents the 80% of the forced vital capacity. It is decreased in obstructive diseases like asthma and emphysema, and it is normal in restrictive diseases. In spirometry, if FE1 is less than 75%, but greater than 60%, we consider it as a mild obstruction. If it is 50 to 59%, we consider it as a moderate obstruction. And if it is 49%, less than 49%, it is severe obstruction. It mainly reflects the mechanical properties of the both large and medium airways. Coming to FEV1 by Fcc ratio, it is used to differentiate between the obstructive and restrictive lung diseases. Normally, it should be greater than 0.7, that is more than 70%. It is decreased with aging and obstructive lung diseases. It is normal or increased in restrictive lung diseases. Because FV1 is normal in restrictive diseases, FVC is decreased, it is normal or increased in restrictive lung diseases. Post-expiratory time is the time required for the post-expiratory vital capacity. Ideally, it should be at least 6 seconds. It is decreased in restrictive lung diseases, less than 3 seconds. It is more than 6 seconds in obstructive lung diseases. Post-expiratory flow, 25, 50 or 75%, it represents the flow of the exhaled air measuring in liters per second at 25%, 50%, 70% of the FVC. That is, FVF 25% is the flow and 25% of the FVC has been expired. Maximum mid-expiratory flow or FVF 25 minus 75 is the average flow during the middle half of the FVC. This represents the effort independent part of the FVC because the initial part is effort dependent. It is more sensitive in detecting the early obstruction in the small airways. Clinical usefulness is limited due to wide range of normal values. And in spirometry, we consider if it is 60%, it is normal. If it is 40 to 60%, mild obstruction. If it is 20 to 40%, moderate. And if it is less than 20%, it is severe. Peak expiratory flow rate is the maximum flow of air during a forceful exhalation. That is maximum flow rate achieved during the forced vital capacity maneuver. Immediately after the start of exhalation, it is effort dependent. Normal peak flow is 450 to 550 liters per minute in adult males and 320 to 470 liters per minute in adult females, that is 4 to 5 liters per second. It is a sensitive test for obstructive lung diseases, useful for assessing the effectiveness of the treatment. Maximum voluntary ventilation is the maximum volume of air that can be breathed with the voluntary effort in 1 minute. And how it is performed is the subject is instructed to breathe as hard as possible and as fast as possible for 10 to 15 seconds, and the results are extrapolated to 60 seconds and reported as liters per minute. Normally, it is 150 to 175 liters per minute and it also can be roughly estimated as FEV into 40. It is decreased in obstructive and restrictive lung diseases.
There is no audio. But Sindhura, there is no audio. Video also.
Excuse me, sir, there has been.
I think there is a problem. Chairperson, sir, we can go ahead with the next topic. Then she can come and join.
Okay.
You please proceed with SARS topic.
Okay. Dr. Sindhura, you cannot connect. Okay, then we can proceed with the next topic. I invite the next speaker, Dr. Professor Viresham sir. Namaste, sir. And it is always a pleasure to meet you. So we'll start with your presentation if you are ready, sir.
Yes.
We are all eager to hear you.
Yeah. Yes, sir. Thank you. Let me.
Dr. Sindhura, you
Am I
stop
audible, sir?
sharing. You stop sharing. You can continue next to sir. We have announced. You stop sharing because or else it will be difficult for the sir to share the screen.
Okay, sir.
We will continue later.
Okay, sir.
Sir?
Yeah.
So you are ready? Proceed, sir.
I am sharing. I'm not able to.
Sir, if the technical team can help him, sir.
Yeah. I'm just. Your screen sharing, it is coming, but it's not reflected.
Sir, stop share, stop and try again, sir.
Okay. What is this? Another thing is coming. L. I'll minimize and do it. My video is not there. Hello?
Yes, sir, we can see the PPT, sir. Run the PPT, sir.
Yeah. Then I will go with that. Okay.
Yes, sir. Start from the beginning.
Good evening. Thank you for giving me this opportunity to participate in the Pudukkottai webinar. It is 20th webinar, weekly webinar. It is the respected AL Meenakshi Sundaram, and my chairperson is Dr. Jayashankar Jana, and the president of the Pudukkottai branch, Suresh Kumar, and secretary Periya Swami and David, and executive members. I thank you each and every one of this ISSCT branch. Now my talk is on, am I audible, sir?
Yes, please go ahead, sir.
My talk is on anesthesia for bronchoalveolar fistula. I am working as professor in GEM Srikakulam after my retirement from the government service. Now, so main objectives of this bronchoalveolar fistula is to describe the risk factors for bronchoalveolar fistula due to this fistula.
Sir, sorry for the disturbance, sir. You can go to the slideshow mode.
Slideshow mode.
Slideshow. You click slideshow. Then from the beginning. Slideshow is here. Slideshow. Yes.
This is there, slideshow.
Then from beginning. Now you click the slideshow.
share the slideshow.
Sir, slideshow is here. Can you see that? No, your arrow is here. You bring it here.
Where?
Slideshow. See, file, edit, view, insert, format, arrange, tools, and slideshow.
Okay.
Next,
Yeah.
to move. Move to your left. Next.
Arrange.
Next.
Tools.
Slideshow. That is the thing. Click.
Yes.
Play from start. Click. Right.
Yeah. Okay, thank you. So main objectives of this broncho, why we should know about this bronchopleural fistula of anesthetizing. There are more risk factors involved with bronchopleural fistula. And the main objective is to outline the diagnostic techniques of these patients with bronchopleural fistula, to explain the conservative and invasive treatment option for the management of patients with bronchopleural fistula, and review the interplay among the interprofessional team in diagnosing, treating, and rehabilitation of the patients with bronchopleural fistula. By definition, the bronchopleural fistula is the communication between the tracheobronchial tree and to the pleural space. If there is additional communication to the surface of the chest, it is called cutaneous bronchopleural fistula. Classification of bronchopleural fistula depending on the type of bronchopleural fistula, it can be bronchopleural fistula, and another thing is alveolar fistula, which is having communication with the alveolus of the pulmonary tissue to the pleural space. And when bronchopleural fistula, communication is between the main stem or lobar or segmental bronchi to the pleural space. So as per the leaks, how much leak they are having, depending on that, Carfolio has classified these leaks into 3 or 4 types. Those are coming on mechanical ventilation. Like largest being is usually uncommon, but it will be continuous. Both the leaks are both in the inspiration and expiration. Whereas a second type of it is only in inspiration, third one is expiration, and one is with the forced expiration. Example like coughing, the fistula leaks. That is one more this thing, classing. And how do you grade this? The grading is like what we have told about is forced expiration, that if the fistula is leaking, then it is called grade 1. In expiration only, it is grade 2. In inspiration only, it is grade 3. In grade 4, it will be like a bubbling gas leak present in the leak chamber during the inspiration and expiration. We know what is the etiology behind it. Most of the times it is post-operatively, it will be after pneumonectomy. Usually, and it will be after pneumonectomy is the very commonest of all the factors. It is up to 4.5 to 20%, and the non-operative, non-post-operative causes are like spontaneously with lung abscess, emphysema, cavity in the bronchial tree, erosion of the bronchus by due to malignancy or chronic inflammation, infections, and traumatic rupture of the bronchus, bulla or cyst, barotrauma, like increased PEEP also can produce into non-operative bronchopleural fistula. And there are also, just a minute. Penetrating chest infusions also can contribute to the bronchopleural fistula. What are the predisposing factors? Most of the time, perioperative radiotherapy, those who have gone for after surgery of the malignancy and subjected for radiotherapy, then followed by the there is a weakness, there is a necrosis of the tissue, and that will lead to fistula. And residual neuroplasm also can lead to this. Infection at the resection site also, and long avascular bronchial stump also can predispose for this bronchopleural fistula. Clinical presentations are according to time. First week is early, and the second is between first to 4 weeks, and the late is after 30 days. Usually, first week to second week, most of the times it is the post-operative bronchopleural fistula, we will find it. The clinical features, how it will present. Most of them, sometimes in acute presentation, sometimes in subacute presentation, sometimes it will present like chronic presentation. Sudden onset of dyspnea, severe in nature, and cough with hemoptysis, purulent material, and hypotension, subcutaneous emphysema. Shifting of tracheal mediastinum to other side will cause dyspnea. So that is, and subacute cases, those are all insidious in onset. They are malaise people, and they might be having some fever, wasting, and with the least productive cough. And associated with the infection disease, they will be in the chronic in nature. And they are very common in sepsis and ARDS patient, and in lobectomy patient, persistent air leak with purulent sputum and drainage are diagnostic features of this thing. Diagnosis, by clinical diagnosis, we can say sudden onset of dyspnea or subcutaneous emphysema, or immediately after removal of ICD drain also with fever, purulent sputum, new air fluid level in chest X-ray, and persistent leak after lobectomy. These are the clinical history we will find. These cases, clinical diagnosis we can do. And investigations to diagnose this bronchopleural fistula is like routine blood test, raised total counts with increased neutrophilia, and arterial blood gas analysis with hypercarbia, hypoxia, and metabolic acidosis, chest X-ray, air-filled pleural space, and new air fluids with shifting trachea, collapse of the lung. Sometimes we should go with the bronchoscopy, and we need even bronchography and sinobronch will be the confirmatory for bronchopleural. And sometimes we will do dye injections with water-soluble injections like methylene blue into the pleural space. Then we can get that blue-colored tissue in the sputum, in the cough with sputum. So this is post-pneumectomy. Usually bronchopleural fistula we are seeing in the right side of the chest film. We have a hydropneumothorax, and fibrinotic broncho is showing possible fistulas opening at right bronchial stump in the right side of this thing. These are the some feelings. Blue dye injection also is there. Signs of chest X-ray with bronchopleural fistula is steady increase in intrapleural airspace. Appearance of new air fluid indicates level of bronchopleural fistula. Development of tension pneumothorax also in favor of in the chest X-ray in favor of bronchopleural fistula. And a drop in air fluid level also. Sometimes it will detect the place, and the size of the fluid level also is important to note the fistula level. Then acute post-pneumonectomy, the BPF also will produce tension pneumothorax and pulmonary flooding. And CT bronchography will help you to go for pneumothorax identification, pneumomediastinal shift. Any underlying pathology also can be known, and demarcation of actual fistula communication also can be noted by CT bronchography. And fiber optic bronchoscopy usually confirms and localizes the fistula. Visualization of a continuous return of air bubbles on bronchial wash while you are doing bronchoscopy. And bronchoscopy allows you to inspection of the stump. How much leak is there? What is the status of the stump? And selective installation of this dye also makes you to appear in the chest drain. Most of the bronchopleural fistula patients will be with the ICD drain. And sometimes fibrotic bronchoscopy aids in placement of balloon-tipped catheter in smaller BPF to avoid leak. So ventilation scintigraphy using xenon 133 and arterial blood gas analysis also will make you to go for. Now, how do you manage initial management for acute situation? Address life-threatening conditions like tension pneumothorax, pulmonary flooding, and drainage of the air and fluid by thoracotomy tube, and treatment of infection by respective antibiotics with cultural sensitivity, and you should improve the patient nutritional status by giving good nutrition support. And what is the next step we are going to do is, so many factors will determine the next options like medical conditions of the patient and time of onset of the fistula, size and location of the fistula, state of the pleural cavity, mechanically ventilated patient, how they are doing it. And available options are Parat, conservative management, revision surgery with muzzle flap, and the completion of pneumonectomy if it is left over, and surgical debridement of the to control the infection. And this can be done with the transpleural approach or transsternal transpericardial approach, or with thoracoplasty or bronchoscopic approach. Now, algorithm for management of bronchoscopic fistula is tube thoracostomy and supportive care is important. Less than 14 days and more than 14 days. Usually less than 14 days, we will be going for surgery. We are going for surgery with muzzle flap, and after 14 days, usually we will be going for, if the patient is fit, we will go for fistula closing with thoracotomy or targeted antibiotics. And if it is more than 8 millimeters and fit patient, we can go with the open window thoracostomy. And these are the modalities of approach, algorithm for management of bronchopleural fistula. Conservative management, like early and small fistulas with less than 1 millimeters, and late and small fistulas with unfit patients. Patients on mechanical ventilator, we will go with drainage and pleural irrigation with antibiotics, nutritional support, help to all these things to close the fistula. It can be supplemented by sometimes video-assisted thoracotomy and with pleural debridement to speed recovery. Bronchoscopic closure in unfit patients will be done in conservative management. So management, it is a medical and a surgical. And the medical, usually for small and chronic fistulas with infection, we will do it. Usually it will be done with the bronchoscopic guided placement of glue or coil or sealants. And surgical is revision of bronchial stem, decortication of the lung, closure of the fistula with muzzle flap. These are the methods available depending on the cause. And usually the problems encountered before surgery is tension pneumothorax, urgent insertion of chest drain, and immediate airway secure and postural drainage with affected side down for the pulmonary flooding. Anesthetic concerns, most of the time before anesthetizing the patient with bronchopleural fistula, patients, most of the patient consent, surgery, time and place, and anesthesia consent. So patient consent is diseased lung, we will have it under air leak, pneumothorax, silage, vacuum mismatch, elderly, patients with comorbidities, and they may be suffering with anemia and hypoalbuminemia. And surgery, usually will be during surgery, it is an open chest, and they will be having some bleeding tendency. If bleeding is also there during surgery, these are the problems with anesthetic concern. And the position of the patient during anesthesia and mechanical ventilation, lung ventilation, blood loss, diseased lung, chest tube, choice of anesthetics, and cardiac output management, temperature, fluid and emergency, post-op ICU stay, pain control, and mortality, take care. These are the things we are going to encounter. Anesthetic considerations is usually due to fistula, we are unable to effectively ventilate due to large air leak. And the positive pressure ventilation might increase air leak and across fistula, causing tension pneumothorax and delayed healing of the fistula. And reduced alveolar ventilation, by the way, causes retention of carbon dioxide, and it causes increased acidosis. And reducing the risk of contaminating a healthy lung is very much important when you are doing anesthesia, if empyema is present. Patient-related factors, more than 60 years and with chronic lung disease, and some people with asthma, with smoking history, and obese patients, they have problems with obstructive sleep apnea, pulmonary hypertension, with heart failure and general health status. These are the very important things we should take care of the patient before taking for anesthesia for surgical repair. And surgical site also is important. How to proceed with that is open thoracotomy or video-assisted thoracoplasty or thoracotomy surgery. And duration of the surgery also we should plan it. If it is more than 4 hours, we will encounter problems during the anesthesia and surgery. If very high-risk patient is less ambulance prefer procedure, we should go with the now changes in pulmonary function with anesthesia. Both lung volumes will be decreased. Diaphragm function also will be minimized. It is basal lung atelectasis is very common with the diaphragm movement, and gas exchange, impaired gas exchange, and control of the breathing also will be decreased due to the drugs, effect of drugs, and lung defense mechanism. Already the patient is a morbid patient with decreased impaired cough reflex and mucociliary function. And post-operatively, they may encounter some problems. Position of lateral decubitus data. Usually, whenever you are taking the patient, it should be above and dependent lung. Like you see, wherever the fistula is there, whenever you are taking the patient to the OT, you should shift the patient with towards the fistula side should be lower level when compared to the other side, and it should be in the upper position. Lateral decubitus position, what happens usually in awake patients is usually there are lungs having 3 zones in erect position. 1, 2, 3 zones are there, but when it is in decubitus position, it will come to the 2 positions in lateral decubitus because of compromised ventilation in the upper lung and the improved ventilation, compromised perfusion to the upper lung, increased ventilation to the upper lung, and increased ventilation to the lower lung, and increased perfusion to the under lung. Both the lungs will compromise in an awake patient. It will become equal when the patient is in erect posture. Lateral decubitus, spontaneously breathing patient. Non-dependent lung, decreased perfusion, decreased ventilation. Dependent lung, increased perfusion, increased ventilation. Anesthetized patient, usually there is a due to diaphragmatic paralysis during anesthesia, there is a upward shift of the diaphragm and the lower side due to the increased abdominal contents, and tone also will be decreased, and there is decrease in the FRC in both the lungs, not only, but compared to dependent lung, right lung, upper lung will not be that much. So it is what happens in the volume pressure curves in awake patient, lateral decubitus position. We have seen volume pressure curves when the lateral decubitus position in awake patient, upper lung is at the plateau level. When it is anesthetized, the upper lung will come into the upward, it is a straight line, and the lower lung will come into the static lower level. So that is the change you will find during anesthesia. Physiological changes, what? Ventilation, perfusion effects will be there. Collapse of one lung with lung isolation technique results in the right to left hand, which leads to vacuum mismatch and hypoxemia. This hypoxemia will help you to position improves hypoxic pulmonary vasoconstrictions and the opposite in the upper lung, and this improves the circulation to the lower lung. So in other words, it will help to the lower lung whenever this HPV is there. Due to that physiological changes, we are able to do anesthesia in bronchopleural fistula cases. One lung ventilation indications are like absolute indications. Usually, this is absolute indications, usually to prevent contamination of the healthy lung by the infections or the massive hemorrhage. And not only that, control of distribution of ventilation to only one lung. It is possible, it is common in bronchopleural fistula, bronchopleural cutaneous fistula, unilateral cyst bullae, major bronchial destruction or trauma. Unilateral lung valve also it is helpful for one lung ventilation. And video assisted thoracoscopic surgery also, one lung ventilation is required. Relative indications are surgical exposure, high priority thoracic aortic aneurysm, pneumonectomy, upper lobectomy, surgical exposure, lower priority middle lobe lobectomy, esophageal resection, thoracoscopy, thoracic spine procedures, post removal of totally excluding chronic unilateral pulmonary emboli. These are the indications for one lung ventilation. How do you assess the patient? Like a history, what is the history we have to take? And examination of general physical status of the patient, estimation of the volume lost through the fistula, quantification of the size of the fistula, and respiration, assessment of the respiratory function, and respiratory mechanics in respiratory function, and lung parenchymal function, and cardiopulmonary function, ventilation, perfusion, scintigraphy. Combination of all these things will help you to predict the post-operative predictability, and post-operative risk can be assessed. And the respiratory function, what are the tests? My junior colleague will enumerate all those things. And pre-op preparation towards the bronchopleural fistula, drainage of the empyema, estimation of the size of the bronchopleural fistula, amount of ICD drain, loss of tidal volume, chest tube position. Chest tube has to be left unclamped to avoid any bouts of coughing and to avoid tension pneumothorax during the before taking the patient for anesthesia and surgery. And you should ask the patient to stop smoking 4 to 6 weeks, and coverage of broad spectrum antibiotics. Hydration of the patient should be improved by humidification, mucolytics, expectorants, and to decrease the wheezing if the patient is having due to infection or asthma, you should supplement with steroids and symptomatology, drugs like cromolyn, sodium, and we can also suggest for breathing exercises to his maximum limits with supplemental nutrition. And pre-op optimization like nutritional, physical rehabilitation, correcting the anemia and hypoproteinemia, appropriate medication, what we have of infection and control and other morbidity, insertion of chest drain, if pneumothorax and empyema with high flow BPF, elective mechanical ventilation if hemodynamically unstable with respiratory failure, and the pulmonary flooding is there. That can be started with mechanical ventilation. Monitors ECG, SpO2, NIBP, TCO2, temperature, urine output. For if you are going for thoracic surgery, airway pressure monitoring is important. Arterial line for invasive monitoring of the blood pressure, and central line for the CVP, and side stream spirometry, and transesophageal echocardiography also. There is a picture on right side of the slide. There is a side stream spirometry is also there. When in the process of induction, soon after you start induction, isolate the lung as as soon as possible and avoid tension pneumothorax. And oxygenation and ventilation is the priority, not by controlled mechanical ventilation. And do not clamp the drain and avoid controlled mechanical ventilation. Avoid suction in the drain. That is also very important during the induction. Induction and intubation should be with 100% oxygenation. Most of the time, sitting up position preferred pre-induction to prevail spillover of the contents, contaminated content. Suction from the chest tube is avoided to prevent loss of tidal volume. Endobronchial tube placement on side opposite to the fistula. DLT placed using fiber optic bronchoscope. Usually pediatric bronchoscope will be using it. Outpouring of pus may be seen from the tracheal lumen. It should be suctioned immediately to the channel. And most of the times it is awake fiber optic intubation with double lumen tube is indicated for isolation of the other lung in one lung ventilation. And usually it's a safest technique, but it requires patient cooperation and thorough airway, topical agent. Sometimes we may induce with spontaneous ventilation under induction and try to avoid the intermittent positive ventilation during the induction time or before, even with the mask ventilation. If airway thought to be easy, modified rapid signal can be done, avoiding IPPV until lung isolation is achieved. Sometimes single lumen tubes are safe to use if fistula is small, chronic, and uninfected. Maintenance is avoid nitrous oxide and high FiO2 valves. You can give oxygen, air, and a little bit of CO for induction, not more than 1 Mach, because it will decrease the hypoxic pulmonary vaso. HPV will be in clinical trials in the dogs. HPV is not done. So, and then we can go with the fentanyl, Vecuronium, intermittent doses. IPPV with to the healthy lung, normal tidal volume about 6 ml per kg, and with smaller tidal volumes to affected lung can be given. High frequency spirometry ventilation may be used along with permissive hypercarbia. Blood loss, you should be careful, and fluid management restricted. Not restricted, it is like adequate, not adequate, it's fluid, mandatory fluid should be given. Suggested ventilation parameters for one-lunged ventilation is inspired oxygen concentration should be adjusted to maintain the SpO2 about more than 90%, and tidal volume about 6 ml per kg for ideal body weight, and concentration of FiO2 should be 0.8%. Mode of ventilation should be about pressure control ventilation preferred mode compared to volume control ventilation. Respiratory rate should be 12 to 14 breaths per minute. In obstructive lung disease, 8 to 10 breaths per minute. And inspiratory-expiratory ratio should be about normal patients without any comorbidities of lung. We can go with 1:2. In restrictive lung disease, it is 1:1. And obstructive lung disease, we can go for 1:2.5 to 1:4. And predictive positive and expiratory pressure in normal and restrictive lung disease, it is 5 to 10 centimeters we can maintain. Obstructive lung disease, we should reduce it to 2 to 5 centimeters of water. Minute ventilation adjusted to be about PaCO2 should be less than 40 to 50, and target airway pressure should be less than 35, and artificial recruitment can be done during the ventilation procedure. And hypoxic, what about pulmonary vasoconstriction? Because if you give decreased perfusion to the upper lung and increased ventilation causes hypoxia to that no gas exchange. So hypoxia will be there. Due to that, it will divert the blood to the dependent lung. So this will prevent hypoxic, decrease the HPV is common with, usually in dogs, they have done it. Inhaled anesthetics and alkaloids also can do the decreased HPV. Hypocapnia and vasodilators like sodium, nitroglycerin, calcium channel blockers also should be avoided whenever you are doing this one lung ventilation with DLT with thoracic anesthesia. Methods of suppression, W-lumen endobronchial tubes, like Robert Shaw, Carlens, with different sizes, French cages, it will be available. 26 French in the smallest size, W-lumen tube, used for children as young as 8 years. For females, less than 1.6 centimeters, we'll be taking 35 French gauge. More than 1.6 centimeters, we'll be taking about 37 of French gauge approximately. Not it is not directly. And males more than 170 centimeters, 41 grade, less than 170 centimeters, 39 French gauge. Usually on that basis we'll be taking. And also length also we can calculate and do it. But usually 26 French gauge smallest size will be used for children as young as 8 years. Yeah, 28 to 32 French gauge for pediatric patients, 10 and older bronchial, single lumen tracheal tubes, bronchial blockers, even arterial embolectomy catheters like Fogarty, single lumen endobronchial tubes also can be. Garden green tube also can be used. So options for lung isolation is, which is better for which place? Double lumen tube. What are the advantages? It is easy to place successfully and the repositioning is rarely required. The bronchoscopy to isolate the lung is possible. Suction to isolate lung, isolated lung is possible. CPAP easily can be added and can alternate one lung ventilation to either lung can be easily done. Placement still possible if bronchoscopy not available by auscultation method. We can. Disadvantage with double lumen tube is site selection is more difficult to place in patients with difficult airway or abnormal trachea, not optimal for postoperative ventilation, potential laryngeal trauma and potential bronchial trauma if you use improperly. So bronchial blockers are the best device for absolute lung isolation. Site selection is rarely an issue. Easily added to the regular endotracheal tube, allows ventilation during placement, and easier placement in patients with difficult airway and in children. And post-operative two-lung ventilation by withdrawing blocker can be done. Selective lobar lung isolation is possible. CPAP to isolate lung possible. These are also about ONT, Cohen, and Fcc and easy bronchial blockers are there. ONT is can be added to the regular endotracheal tube. Cohen tube allows ventilation during placement. That is one advantage Cohen bronchial blocker is having. Fcc, we can easily place the bronchial blocker in a difficult airway patients. So disadvantage, more time needed for positioning of the bronchial blockers. Repositioning needed more often due to the position change. Bronchoscopy is essential for positioning. Limited right lung isolation due to right upper lobe anatomy. Bronchoscopy to isolated lung is impossible. Minimal suction to isolated lung. Difficult to alternate one lung ventilation to either lung. And univent tubes are also available, same as bronchial blockers. Less repositioning compared with the bronchial blockers, rarely used. And the same as for bronchial blockers. Endotracheal tube portion has higher airflow resistance than regular endotracheal tube. ETT portion has larger diameter than the regular endotracheal tube. So endotracheal tube, easier placement in patients with difficult airways, and it does not allow for bronchoscopy, suctioning, or CPAP to isolate the lung. Cuff not designed for lung isolation, extremely difficult right lung ventilation. These are the advantages and disadvantages of the bronchial W-lumen tubes, bronchial blockers, univent tubes during one lung ventilation. So how do endobronchial intubation is usually accompanied by direct laryngoscopy after induction of general anesthesia and neuromuscular blockade. The left-sided DLT tube is held so that the distal curve faces anteriorly while the proximal curve is to the right while you are intubating. The bronchial cuff is inserted through the vocal cords and the slylight is removed. Next, the tube is rotated 90 degrees to the left, directing the bronchial lumen to the left main stem bronchi. The tube is advanced until moderate resistance to further passage is encountered. This is the how do you insert the left-sided double lumen bronchial tube. So, how to check auscultation? This is a 3-step method to confirm position of the left DLT by auscultation. Step 1 is during bilateral ventilation, the tracheal cuff is inflated to the minimal volume that seals the air leak at the glottis. Auscultate to confirm bilateral ventilation. Step 2 is the tracheal lumen of the double lumen tube is clamped proximally. Clamp the short side short and the port distal to the clamp is open. During ventilation via the bronchial lumen, the bronchial cuff is inflated to the minimal volume that seals the air leak from the open tracheal lumen port. Auscultation, auscultate to confirm correct unilateral ventilation. And step 3 is tracheal lumen clamp is released and the port is closed. Auscultate to confirm resumption of the bilateral breath sound. These are the methods by auscultation method. And one more method, safest method is by introducing the pediatric fiber optic bronchoscope to check and placement of the position of the double lumen tube. Ensure correct position of the DLT by breath sound. Chest raise, the chest raises and fall. Compliance. No leaks are present. Respiratory gas moisture appears and disappears with each tidal ventilation. Fiber optic bronchoscope. Bronchial blockers, we have already discussed about with a reusable bronchial blocker. Magil first described bronchial blocker. Insufflation cuff at distal end of blocker serves to block ventilation of that lung. Conventional tracheal tube is then placed in trachea. Useful in age less than 12 years. Due to high distending pressure, it slips out of the bronchial into trachea, obstructing the ventilation. Advantage of the univent bronchial blocker tube is easier to insert. I have already enumerated. Types of bronchial blockers, univent bronchial blocker system, aunt endobronchial blocker, co-inflexive tip endobronchial blocker. Bronchial blocker independent of single lumen tube. And bronchial blockers have two main varieties, independent catheters that can be placed in single lumen endotracheal tube. Catheters that come mounted inside endotracheal tube as one unit is another variety. So characteristics of the Cohen, aunt, UG and easy bronchial blockers. So the varieties are there. Balloon shaped it is inflator is there. 9 French on blocker, Cohen blocker. Size is about 9 French Cohen blocker. On blocker is 5 available, 5 French and 7 French and 9 French. QG blockers are 5 French and 9 French. Easy blocker are 7 French. So smallest recommended is 9 French and nylon wire loop that is coupled with the fiber optic bronchoscope is present in the on blocker. So these photographs are with some of the photographs of bronchial blockers. Endobronchial intubation with the single tubes. Adults is often the easiest, quickest way to lung suppression. Blind or fiber optic in children, it may be simplest way to achieve. Disadvantage inability to do suctioning or ventilation of the operative side, difficult positioning. Bronchial cuff with inadequate ventilation of the right upper lobe after right endobronchial intubation. One lung ventilation in pediatrics is small double lumen endobronchial tubes available 26 feet and children about 30 kgs, children 8 to 10 years can be used with this. And disadvantage with a narrow tracheal lumen, the small DLT does not allow the use of pediatric fiber bronchoscope to confirm the correct placement. At the end of operation, it must be exchanged with a single lumen tube if the child is left intubated. Single lumen endobronchial tube, endotracheal tube with a bronchial blocker, univent tube, Fogarty embolectomy, the aunt endobronchial blocker can be used in children, even in infants. Ordinary uncut single lumen endotracheal tube, a smaller size by 1 millimeter ID is used, which is inserted endobronchially, it can be used in infants.
Dilesham, sir.
Yeah.
Sir, how much long, sir? Because Sindhura is also ready with the presentation.
Yeah, I'm just finishing. Okay. OLV in patient with difficult airway. Difficult airway needs OLV. Secure in a single lumen tube or the fiber optic bronchohook or LM also can be used temporarily. And independent bronchial blockers also can be done. Intraoperative hypoxia, deliver II for to ensure adequate cardiac output. Reconfirm the correct position of the lumen tube. CPAP to operative lung, PEEP to ventilated lung, intermittent ventilating the operative lung, clamping the main pulmonary artery of the operative lung if an pneumonectomy is planned. So, predictive post-operative FEV1, I think Sundara will cover. Cardiovascular management, intraoperative and post-operative, fluid goal-directed fluid management, liberal fluid management results in poor outcome, no more than 20 cc per kg, positive. Post-operative arrhythmia should be supraventricular tachycardia, which are very common. Atrial fibrillation are very common, you should be taken care. Post-operative change the DLE to SNT, shift to ICU in sitting position after establishment of adequate pond and ventilation. Respiratory failure is very common. And pain relief is the one of the best options. It can be done with the neuraxial blocks, external neuraxial blocks, systemic analgesia. Multimodal analgesia should be complemented. Pain management, 70% of post-thoracic patients experience moderate to severe pain. Post-thoracic pain leads to decreased vital capacity, FRC, impaired cough, retention of secret, atelectasis, hypoxemia, respiratory failure. So these are the pain modality, post-operative pain management is absolute in this patient. Thank you. These are references. Thank you very much.
Thank you, sir. This was a very elaborate presentation by Dilesham, sir.
Sajay.
Very nice presentation. Sir, we have already, Meenakshi sir, we have reached 7:45 p.m. So it's up to you, sir. Shall we take the questions or shall we allow?
You allow madam.
Yeah.
Because she has prepared. Madam, you can give 5 more minutes for her.
Yeah.
Then, Dr. Raigar sir is there. Then Dr. Tanneru Venugopal Rao sir is there. We will ask their opinion also. Then you can go for discussion because we have to wind up by 8 o'clock.
Yes, sir.
Give madam 5 minutes. She can rush the slides.
Yes,
Yes,
madam,
sir.
please.
Yes. Sorry, sir. Due to time constraint, I am rushing. Coming to the spirometry, it is basically performed by a spirometer. There are basically 2 types, those which measure the volume directly and those which derive the volume from the flow rate. This flow sensor will be there, which will calculate the flow rate by detecting the pressure difference caused by a resistive element placed in the breathing tube. And the modern spirometers are a computerized microspirometer, like you seeing in the picture. There are machines, they measure the flow rate. When patient breathes in and out through a mouthpiece connected to the flow sensor, the volume and other derived parameters are calculated by an integrated microprocessor. So 2 manuals will be there in spirometry, that is forced vital capacity manual and slow vital capacity manual. This forced vital capacity manual is standardized and most commonly used. There are 3 phases in the forced vital capacity manual: maximal inspiration, forceful expiration, and a continued complete exhalation. The normal FVC value is 80 to 120% of a predicted value. And slow vital capacity manual is the patient is performing this slowly. The FVC and SVC are similar in normal healthy patients, but in obstructive lung disease, forceful expiration causes dynamic collapse of airways and leads to much lower value of the FVC than SVC. And the parameters obtained in spirometry are FVC, FEV1, FEF 25 to 75%, PEFR, and maximum voluntary ventilation. Results over 80% are considered to be normal. And we get 2 types of graphs: flow volume loops and volume time curves. And the flow volume loops, different diseases produce a different type shapes of the curves. By seeing the shape itself, we can diagnose the disease condition. Every part of the curve represents something, like leftmost end of the curve represents total lung capacity, rightmost represents residual volume, and width represents FVC, height represents PEF, and distance from total lung capacity to the first second marks the FEV1, which is effort dependent, and the descending slope reflects the FEFs, which are effort independent. And this left right side is the normal flow volume loop. And in volume time curve, it reaches the plateau. This is a normal function forced vital capacity. In mild obstruction, it is preserved, but the peak is reduced. Like in flow volume loop, the PEF are mildly reduced and coving will be there. In severe obstruction, the severe coving, PVFR is severely reduced. In volume time curve, in restriction, it looks like a normal, but it is smaller than the normal flow volume loop. These are the acceptability criteria from ATS to know the, spirometry is most subjective. So it should be a good start and there will be good end, and have a satisfactory exhalation, at least 6 seconds of exhalation. It should be free from artifacts like cough, glottic closure, early termination, variable effort, leak, and obstructed mouthpiece. The reproducible criteria is, if we have a 3 acceptable spirograms, the 2 largest FVC and FE1 will be within the 200 ml of each other. Coming to interpretation of the spirometry, first we will assess the FEV1 by FVC ratio. If it is low, look for FVC. If it is normal, it might be mild obstruction. If it is low, it might be severe obstruction or mixed. And if it is a severe obstruction, we will go for post bronchodilator test. Results will help us to know whether the obstruction is reversible or not. If FV1 will be FVC ratio is normal or high, assess for FVC. If it is normal, then normal lung mechanics. And if it is low, assess for total lung capacity. If it is low, there might be restrictive lung disease. But with only spirometry, we can't assess the pulmonary vascular diseases. And then here comes the role of DLCO, diffusion lung capacity for carbon monoxide. If the normal mechanics are there, we'll assess the DLCO. If it is low, it might be a pulmonary vascular disease. If it is normal, there will be normal PFT. In restrictions, DLCO will help us to differentiate between the interstitial lung diseases and chest wall disorders or neuromuscular disorders. These are the contraindications for spirometry: hemoptysis, pneumothorax, and recent eye surgeries, presence of acute disease processes that might interfere the test performance. And these are the things to be kept in mind before spirometry. Advising spirometry, that is short-acting bronchodilators should be avoided for at least 4 hours. Long-acting beta-2 agonists and oral aminophylline should be avoided for more than 12 hours. And avoid coffee. Smoking should be avoided for at least 1 hour. The limitations of the spirometry is it cannot measure the residual volume, FRC, and total lung capacity. These can be measured by the whole body plethysmography, nitrogen washout technique, and inert gas dilution technique. The body plethysmography, the basic principle is Boyle's law. That is, the volume of gas at constant temperature varies inversely with the pressure applied to it. And the technique is, patient is asked to sit in a airtight chamber. This is the airtight chamber. We'll ask the patient to sit here, and a nose clip is applied and the mouth tightly applied to the mouthpiece. We ask the patient to perform a FVC maneuver. The thoracic movements of the patient breathing results in changes in volume and proportional pressure change inside the lung and thoracic cavity of a patient. This is reflected in identical volume and pressure swings inside the chamber, which are measured and evaluated. So the advantage is it is very least invasive and it is accurate. We can get airway resistance also, and the total lung capacity is known, and the gas trapped in bullae also be known. This is the nitrogen washout technique. It is also same based on the Boyle's law, C1V1 equal to C2V2, where C1 is the nitrogen concentration in the lungs at FRC, V1 is the FRC, which we need to know, and C2 is the nitrogen concentration in the container, and V2 is the volume of air in the collecting container. Coming to helium dilution technique, in this, the inert gas is breathed into a closed system with a known volume, that is V1, and concentration also we know. So patient will continue breathing the helium until concentration equilibrium is reached and measure the helium analyzer. So concentration was equilibriumized. Here also we will apply the C1 V1 equal to C2 V2, where V2 is the V1 plus FRC or residual volume, which we want to know. Coming to diffusion capacity for carbon monoxide, it reflects the ability of a carbon monoxide to diffuse into the blood through a alveolar capillary membrane, which measures the rate of gas transfer across the alveolar capillary membrane. So why we using carbon monoxide? It is the following reasons, because normally non-smokers, carbon monoxide in blood and alveoli are very low, almost zero. Hemoglobin, the capillary back pressure is low. Hence, carbon monoxide absorption is diffusion limited. And the technique is, we will give a known mixture, a gaseous mixture containing 21% of oxygen and nitrogen and 10% of tracer gas like helium, and low concentration of carbon monoxide, that is 0.3%. And the exhaled alveolar gas sample is analyzed. Helium is used because to calculate the total lung capacity, and carbon monoxide concentration is used to calculate the amount of carbon monoxide transferred to the blood. The interpretation of DLCO values is like, say, more than 80%, it is normal. If it is 80 to 60%, it is mild reduction. 40 to 60% is moderate, and less than 40 is severe. The causes for increased DLCO is supine position, exercise, obesity, and left to right shunts and intraalveolar hemorrhages. And causes for decreased DLCO is mainly due to decreased surface area and might be increasing due to the increased thickness of the alveolar capillary membrane. That is in sarcoidosis, asbestosis, and collagen vascular diseases. So if we add the DLCO to total lung capacity, we can differentiate the lung parenchymal disorders from the pulmonary vascular diseases. If both total lung capacity and DLCO are decreased, it might be a parenchymal disease. If only DLCO decreased with normal lung mechanism, that is pulmonary vascular disease might be present to the patient. If DLCO is decreased and maybe airway obstruction is present or total lung capacity is increased, that might be emphysema. Coming to the respiratory muscle strength, we will have volitional tests and non-volitional tests. Volitional tests are patient dependent, very subjective. Patient will is required for the volitional test. We will measure the static pressure, inspiratory pressure, and expiratory pressure. In non-volitional test, phrenic nerve stimulation by using nerve stimulator and all. We can differentiate neuropathic and myopathic patterns of a lesion. In this maximum static inspiratory pressure and the static expiratory pressure, the clinical importance is if PI max is less than 25 centimeters of water, indicates the inability to take deep breath, and PE max less than 40 centimeters of water indicates impaired effective coughing. The clinical importance is if PI max greater than 20 centimeters and PE max greater than 40 centimeters, predict the ability to wean the patients from ventilator off in ICUs. Tests for cardiopulmonary interactions include qualitative and quantitative. In qualitative, history, examination, ABG, and stair climbing test, and in quantitative, 6-minute walk test. In stair climbing test, we ask the subject to climb 3 flights of stairs at his own pace without stopping or without any dyspnea. We think that they decreased mortality and morbidity. If he is not able to climb at least 2 flights, he is very at high risk for post-pulmonary complications. In 6-minute walk test, it is very gold standard. Cardiopulmonary reserve is measured by estimating maximum O2 uptake during exercise. It is modified if patient can't walk, we ask him to do arm exercises or bicycle. If patient is able to walk for more than 2,000 feet during 6-minute period or 610 meters, the VO2 max is more than 15 ml per kg per minute. If simultaneously oximetry is done and if SpO2 falls greater than 4%, he is in high risk. These are the bedside pulmonary function tests: De Bono whistle test, Snyder Match-Blow test, Sebr's breath holding time test, single breath count test, cough test, auscultation over trachea, spirometer, right spirometer, peak flow meter, microspirometers, pulse oximetry, AVG analysis. These will help us during the PAC, pre-anesthetic checkup, to just roughly assess the patient cardiopulmonary reserve. I am just skipping the slides.
Yes, Indura, please, because we have to end by 8 o'clock.
And the applications of PFTs, with using PFTs, we can grade the COPD with mild, moderate, severe, and very severe. These gold criteria using FEV1, percentage of predicted. And for predicting post-pulmonary complications, these are the predictors of increased risk like FVC less than 50% predicted if less than FV1 is less than 50% or less than 2 liters. Maximum voluntary ventilation less than 50% of predictor less than 50 liters. These are more prone for postoperative pulmonary complications if a patient is having this type of PFT. For pre-op evaluation for thoracotomy, the 3-leg stool for pre-thoracotomy respiratory assessment, like in respiratory mechanics, we look for the FEV1. If it should be greater than 40% to undergo for lung resection, and maximum voluntary ventilation, residual volume by total lung capacity ratio, and post-vital capacity. In cardiopulmonary reserve, VO2 max should be more than 15 ml per kg per minute. In stair climbing test, at least he should climb more than 2 flights. In 6-minute walk test, after exercise, SpO2 should not fall less than 4%. Lung parenchymal tests in DLCO, post-op pulmonary, more than 40% should be there. And we use this by PFT for post-thoracotomy anesthetic management. Like if it is more than 40% predicted, we can extubate the patient in operating room. If it is in between 30 to 40%, we should consider extubation based on the exercise tolerance and DLCO and ventilation perfusion scan. 30%, if it is less than 30%, staged weaning from mechanical ventilation should be done. And we can use the PFT for predicting post-op, calculating the post-op FEV1 using pre-op absolute FEV1. Thank you.
Chairperson, sir.
Thank you, sir.
Chairperson, sir, you can ask Dr. Venugopal Rao, Tanneru Venugopal Rao, sir. He's a former DME of Andhra Pradesh. He is here. Dr. Lalit Kumar Raigar, he is a senior professor in R&D Medical College, Udaipur.
Yes, sir.
We can take their opinions. I think.
Actually, Dr. Raigar has asked a question. Dr. Raigar sir has asked a question.
Raigar sir has answered that question also. He will answer.
So what is the use of microspirometry? That was a question from Raigar sir.
Raigar sir will answer for that question.
For the previous class.
Welcome, Raigar sir. Welcome, sir.
Bye.
Sir, unmute your mic and please talk, sir.
Sir, continue with the speaker.
Pardon, sir?
She will tell the detail.
Which detail?
Sindhura.
Sir, good evening, sir. Sir, it helps in bedside PFT, sir. It is very, it's like very small PFT, like a pressure gauge like that, sir. We use it for bedside PFT, sir.
Venugopal sir, Venugopal sir, your thoughts.
Sir, Dr. Venugopal Rao, sir, you can talk. I think the connectivity is
connectivity
problem.
Yeah.
I think sir has come. Venugopal Rao, sir. There is a problem. Sir wants to say anything, Dr. Lalit Kumar, sir? If there is no more questions, I think, Chairperson, sir, we can wind up.
Yes, sir. So we are sharp 8 o'clock.
Yeah.
So let's wind up. I thank all our speakers. We must have a little bit enthusiastically overshot the time. So the discussion was a little short. I thank Dr. Lalit Kumar Raigar sir and sir who has joined here. I thank our President, Secretary and Treasurer of ISA Pudukkottai and Dr. Meenakshi sir for conducting this scientific program every week. Over to you, sir. Meenakshi sir.
Sir, I am handing over the session to President, sir, Dr. Suresh Kumar, sir.
Yes, sir.
Thank you, Meenakshi Sundarangara. I am here.
Sir, Dr. Chakrava is here.
Sir.
Chakrava is here.
I could not
Good
come
evening,
in
sir.
time, but
Good evening,
I wanted to greet you for the wonderful job you are doing every week.
Thank you, sir.
I wanted to express my happiness.
Yes,
I don't know what you say, call in Tamil. I'm very happy.
Magilchi. He say Magilchi, sir. Then I request you, sir, you can choose 3 faculty for topics and resuscitation, sir.
Okay.
You give me 3 faculty, 1 resident is compulsory. We will allot the topics and resuscitation.
Okay, sir.
Thank you very much, sir.
Okay, sir. Thank you.
Good evening, sir. Good evening, sir.
Good evening. Good evening. Namaskaram.
Namaskaram, sir. Chakrara, sir, namaskaram.
Namaskaram.
Thank you, sir. Thank you for your presence, sir.
Thank you. Thank you.
Sir, Dr. Venugopal Rao is, sir, is also there, but the connectivity problem, he could not come.
Okay.
That's the thing, yeah. President, sir, Suresh Kumar, sir, please.
Yeah. Thank you. Dr.
Sorry to
Helium,
interfere, sir. Suresh Kumar, sir.
No, sir.
Yeah.
Continue. Please continue.
Yes, sir. No problem, sir. We are very well blessed with your wishes, sir. Thank you. Thank you. Once again, I thank all the dignitaries who have come here all the way. With your blessings, we will conduct the Pudukkottai Buddhan webinar in future. The same memento, same efforts and same force. I thank our chairperson, Dr. Joy sir, speakers, Dr. Visham and Madam and Samir. The session was very useful. This is now the time for vote of thanks. Our treasurer, Dr. David, is waiting. Over to Dr. David. Dr. David, please.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our chairperson, academic chairman, Dr. Helium, sir, for successfully conducting the 20th webinar CME. Thank you very much, sir. And I would also thank today's chairperson, Dr. Jai Shankar Jama, sir, for sharing his wonderful experiences. And also thank our speakers, Dr. Visham, sir, and Sindhura ma'am, and Dr. Samir, sir, for a wonderful academic session. And thank other faculties and thank Accuralaw and A1 Logics for technical support. Thank you, sir. Thank you.
A1 Logics, you can enter the meeting.
Thank you, sir.
Thank you.
Thank you.
Thank you
all.
Thank you all. Thank you very much.
Thank you, sir.
Thank you.